visible and am I audible? Is my screen audible and visible,
Yes,
sir?
yes.
So, thank you, Bansal sir, for this wonderful opportunity. My topic is role of azithromycin, doxycycline, and minocycline in perspective from intensivist. So let me start by saying that this is the problem of society, that everybody wants antibiotic, nobody wants perfect diagnosis. So whenever we talk about antibiotic, we should understand about the pathology, about the microorganism, about PKPD parameters, and what are the harm which is created by giving antibiotic. So we all know that discovery of antibiotic was good between 1920 to 1999, and after that there was a decline in the newer molecule. So let me start with first case. He is a 73-year male patient, diabetic, hypertensive. He had a fever with headache of 3 days and new onset of tremor, ataxia, and dysarthria. MRI was done outside, which was normal, and he came to our hospital with above symptoms. On examination, he was vitally stable. He had a 101 fever, mild terminal neck rigidity, and rest of clinical examination was normal. WBC count was high, CSF was normal. Uh, on the screening, we found there is a right lower lobe pneumonia. We can see the dense patch on the right lower lobe. So we did following things. We have sent the cultures, but cultures were sterile. Pneumococcal antigen in urine is negative. Pneumococcal antigen in urine has poor sensitivity but good specificity. Legionella antigen in urine was also negative. Mycoplasma IgM was negative, and chlamydia pneumoniae IgM was positive. So finally, our diagnosis was community acquired pneumonia due to chlamydia pneumoniae. Now we have learned that these atypical pneumonia usually don't cause consolidative opacity, but in our practice we have seen that this atypical pneumonia can cause the dense consolidation. So we have started this patient on ceftriaxone 2 gram IVBD and azithromycin, and he improved with this treatment. When we talk about azithromycin, this so azithromycin is overused antibiotic in OPD practice. So whenever any patient goes to physician or any general practitioner, so usually when they see such a red throat, azithromycin is commonly prescribed. So I would term this disease as a augmentin azithromycin syndrome, that most of these illnesses are viral, and it doesn't require azithromycin. There are various reasons why it is overused, because of it is low cost, easily available. There is no knowledge about resistance in India, which is actually high in India. People feel that it has no harm and no side effect, but it causes QT prolongation. And sometimes many doctors give good justification that it has a anti-inflammatory properties. So let me talk about, so azithromycin belongs to macrolide group. The mechanism of action is, it is the bacteriostatic drug. It inhibits the 50S ribosome subunit, and thereby it inhibits the growth. It has a long half-life intracellularly. In serum, it has a half-life of around 24 hours, but intracellularly up to 96 hours is the half. So it has a good intracellular penetration. Whenever we talk about antibiotic, first we should understand that what it doesn't cover. So it will not cover staphylococcus, enterococcus, enteric gram-negative organism, and the anaerobes. So mainly it covers the strep pneumoniae, Salmonella typhi and paratyphi, um, Moraxella, H. influenzae. Atypical mycobacteria is also well covered with the macrolide, H. pylori, chlamydia, Neisseria gonorrhoeae, and the strep pyrogens. So these are the organism which is commonly targeted for the targeted by azithromycin. So from intensivist perspective, what can we discuss about azithromycin? So I have three things to discuss. One is, can we use empirically in ICU? So, and yes, then in which group of the patient? What are the adverse drug reaction we should see when we write azithromycin? And most important thing is a drug interaction. So empirically, CAP, community acquired pneumonia, in which most of the guideline mention that you can start beta-lactam antibiotic and one macrolide. So this is the standard guideline by majority of the society. Acute undifferentiated febrile illness. So when patient presents to you with very high grade fever, toxic symptom, and on the history, when you don't localize that what could be the site of sepsis, in this patient, you can empirically consider azithromycin after sending the appropriate investigation. And the post-influenza and post-COVID dense consolidation, because the most common co-infection, or we can say a super infection associated with influenza and COVID, is a strep pneumoniae. So in that case, again, you can consider macrolide along with the beta-lactam antibiotic. But people feel that azithromycin don't have a side effect, but it is associated with significant hepatotoxicity. So we have seen a few patients who developed hepatotoxicity, cholestatic jaundice. So please watch for SGPT, SGOT whenever you write azithromycin. Second thing is a QT prolongation. So most of the drug, whenever we check the treatment sheet, so there are multiple drugs like fluconazole, there are certain anti-epileptic, fluoroquinolones, azithromycin. So this all causes QT prolongation, and they have an additive effect whenever we talk about QT prolongation. So always see QT interval every second, third day you write azithromycin in ICU when other QT prolonging drugs are prescribed. So important thing to remember that it is metabolized by CYP3A4. So those drug which inhibits the CYP3A4 can increase the concentration. But among the macrolide, erythromycin is majorly affected, followed by clarithromycin and the azithromycin. Okay, so the question many intensivists and many doctor ask that can we give azithromycin to all the CAP patient, and what are the data regarding resistance is saying. So important thing is to remember there are two mechanism of resistance in strep pneumonia. One is the B related, which is high level resistance, and second is a MEF gene related, which is a low level resistance. So OMB related resistance, it is not a good resistance because in which we can't use azithromycin. It is majorly seen in the European and the Asian countries. So in India, both OMB and MF gene associated mutation is rising. So nowadays data is showing that macrolide resistance is rising in the community. While MEF gene related is a low level resistance, in which despite resistance you can use azithromycin. Uh, it is seen in the USA, Canada, and the UK. Nowadays, many consultants prefer doxycycline as the emerging option for the community acquired pneumonia. So one beta-lactam antibiotic along with the doxycycline is the emerging option of CAP. Let's move to another group, that is a tetracycline group. So nowadays we do see tetracycline is use of tetracycline is rising. So there are three drugs. One is a tetracycline, doxycycline, minocycline, and TG-cycline. So I will talk about doxycycline and minocycline. TG-cycline will not be covered in this topic. So again, they are the bacteriostatic drug. It inhibits the 3S ribosome subunit. Although azithromycin, doxycycline, minocycline, they inhibit the ribosome subunit. They are the bacteriostatic drug, but all have a different properties. So it was a saying that doxy is good, mino is better, and TG is better, but thing like that. Everyone has a unique property, and we will discuss about that. So first antibiotic is a doxycycline. So let's understand that doxycycline has a very good intracellular penetration. It has a good level in the sinus, liver, and knee. So good drug whenever we talk about sepsis originate from this site. Second, it has a moderate concentration in the bronchial secretion and the pleural fluid. Genitourinary tract, CNS, aqueous humor, and the fluid. So what it covers? Mainly it is targeted for atypical respiratory pathogen, Rickettsia, spirochetes, plasmodium. We know that it is used for the second line agent along with the artesunate. Staphylococcus aureus, very good drug in oral step down therapy for MRSA infection. Strep pneumoniae, as I said, as macrolide resistance is rising. So DOXY is one of the emerging.
Dr.
Yes.
Pratik, your share screen has gone.
Am I
Yeah.
visible?
Yeah, you're visible now. And just share again.
So where
Okay.
I was disconnected, this was the last slide.
Yeah, this was the last slide.
Okay. So doxycycline achieves moderate concentration in the bronchial secretion, pleural fluid, genitourinary tract, CNS, aqueous humor, and the peritoneal fluid. So DOXY is a good antibiotic whenever we target atypical respiratory pathogen, Rickettsia, spirochetes, Plasmodium species, Staphylococcus aureus. So nowadays it is a good agent for a oral step down therapy of MRSA infection. Strep pneumoniae, as I said, that macrolide resistance is rising. So in a CAP treatment, we can consider DOXY as an empiric therapy along with one beta-lactam antibiotic. Stenotrophomonas maltophilia, but again, Mino is better than the DOXY. That DOXY is not good for most of the gram-negative pathogens, anaerobes, enterococci, and the beta-hemolytic streptococcus. So what are the adverse drug reaction associated with the doxycycline group? So photosensitivity, GI upset that we have seen with the doxycycline. So we ask all the patient to take doxycycline with a full glass of water. Discoloration of teeth is particularly seen with the minocycline. Tissue hyperpigmentation again with the minocycline, intracranial hypertension, vestibular toxicity more with the minocycline, esophageal ulceration, and very rare cases of pancreatitis. So from intensivist perspective, when can we give doxycycline in ICU? So which are the syndrome? So whenever we treat acute febrile illness with the ARDS, uh, then CAP, community acquired pneumonia empiric treatment, acute febrile illness with the skin rash because we want to target rickettsia, acute febrile illness with the multi-system involvement, like hepatorenal syndrome with the leptospirosis, again a liver enzyme elevated, renal injury, ARDS, so that can be seen with the rickettsia. Complicated malaria, so whenever we see any malaria which is associated with the end organ dysfunction, so along with the artesunate we can consider doxycycline as a second line therapy. So Uh, so doxy is a important agent for this particular syndrome. We know that Acinetobacter cases, hospital-acquired Acinetobacter baumannii is rising role for hand. Uh, so basic basic idea of minocycline, it is to target the drug resistance Acinetobacter baumannii. So majority of data says that Acinetobacter baumannii, they are the carbapenem resistant and they have a good susceptibility for colistin and the minocycline. So minocycline is one of the emerging option for the treatment of Acinetobacter baumannii. is the advantage of minocycline as compared to other tetracycline? So particularly this pathogen like Burkholderia cepacia, E. coli, Serratia, and the Stenotrophomonas maltophilia. So these are the pathogen. They are better targeted with the use of minocycline, and that we have seen in our clinical practice that data is also showing good susceptibility. Okay, so what is the advantage of minocycline over TG cycline? So when can we, sometime we see that both is sensitive in the culture report. So when to prefer minocycline? So let's remember that TG cycline do not achieve a good serum concentration with a regular dose. But now most of the clinician and intensivists, they are using the double dose, which can achieve a good concentration in the serum. But Mino has a good data regarding the good serum concentration. Mino has a good lung tissue penetration. Even it has a good level in the alveolar cell wall. So it is a good drug whenever we treat the hospital acquired pneumonia. One of the advantage of minocycline is oral switch is possible whenever we want to complete like 2-3 week therapy. But again, whenever we switch over, I don't know whether it will achieve a good concentration or not. And it is approved for HAP, WAP, and UTI, where TG cycline doesn't achieve a good concentration in the lung, in the serum, in the urine. So that will be achieved with the minocycline. The disadvantage is the susceptibility issue. So from intensivist perspective, when can we consider minocycline in our therapy? So those ICU which has a high rate of carbapenem resistant Acinetobacter. So whenever you send a ET culture, whenever you suspect a hospital acquired pneumonia, and ET culture when there is a GNP and your microbiologist tells it's a non-fermenter. So there are main two non-fermenter. One is a Pseudomonas and second is a Acinetobacter. So in that case, if you know that in your ICU the high rate of CRAB is there, you can consider minocycline initially. And of course, if the culture report, if sensitivity report is different, you can change to other therapy. And then other syndrome is when there is a new onset of sepsis on meropenem and polymyxin B. uh, in that scenario, you can add empiric minocycline just to cover Burkholderia cepacia and the Stenotrophomonas, because these are the which is mostly seen in the second and third sepsis in ICU. So initially, majority of the ICU start with the gram-negative organism. All the Enterobacter, most common pathogen is a Enterobacteriaceae group. But if there is a new onset of sepsis on meropenem and polymyxin B, you have to consider this atypical pathogen and the fungal infections. This is the recent study by Dr. Parikshit from Indian ICU, and he did analysis of 50 cases of carbapenem resistant sepsis caused by carbapenem resistant Acinetobacter. So the most common enzyme was OXA23, and in the culture report there was very high rate of aminoglycoside resistance, while minocycline was susceptible better than the TG cycline. If you talk about my city, in our hospital, TG is more sensitive than the minocycline, but this data shows that minocycline was susceptible than the TG cycline. What how we give? So loading dose is 200 milligram BD on the first day, and from second day 100 milligram twice a day. It is predominantly eliminated by liver and the biliary tract, so it doesn't require a renal dose adjustment. But we have seen few cases of minocycline induced renal injury. So we can't say clearly that mino is safe in CKD patient or those who are on the acute kidney injury. But yes, you have to the trend of parameter whenever you prescribe minocycline, and you have to watch for liver injury whenever you prescribe minocycline. So one of the common problem with minocycline is minocycline induced hyperpigmentation. So both skin and the gum and teeth pigmentation has been seen. Now most of the ICU drug are associated with the hyperpigmentation. So that we do see with the polymyxin B. And again, this minocycline is also causing the tissue hyperpigmentation. So I think that's all from my side. I'm ready to answer a question in the end if you have any question regarding this topic.
Okay. Thank you, Dr. Pratik. Very nicely elaborated, and really appreciate that. So we'll take the question in the end. That's okay, Dr. Pratik, or you want the question now?
No, we can take question at the end. I am available.
Okay.
I'm available.
Okay. So, Dr. Surbi, over to you. Please share your screen.
Very good evening, everyone.
So
And
Dr. Surbi Madan is an infectious disease consultant at CMIS Marengo Hospital, Ahmedabad. She has won the Times Power Woman Award, Asia ICC Iconic Healthcare Leader Award in 2021, and she was on the panel for India COVID guidelines. So she'll be speaking about a very important topic, that is Candida infections in the ICU. Over to you, Dr. Surbi.
Yeah. Sorry, just one second. I congratulate Pratik for a very nice talk. Just give me 1 minute.
Yes, please. No.
Is my screen visible?
Yeah, your screen is. You are visible, but your presentation is not visible.
My presentation is not visible?
No.
Just 1 minute. ભાવેશ ભાઈ શેર કરજો ને, સ્ક્રીન નથી થતું મારાથી. મારી સ્ક્રીન શેર કરો ને પ્લીઝ. ફટાફટ કરો ને, વેટ કરે છે. નથી. હા હા. Is it visible now?
No, Dr. Surbi, not yet.
I'm sorry.
It's okay, it's okay.
Is it visible now?
Yes, Dr. Surbi.
Yeah. So very good
You have
evening,
to go full
everyone.
screen, please.
Yeah. So we are going to talk about a very important topic today, that is Candida infections in ICU. Now we know that invasive candidiasis in critically ill patients is rising, and it has become a very challenging problem. And it is mainly because of the expanding population of high-risk patients, use of broad-spectrum antibiotics, and increase in the prosthetic devices. Now, early diagnosis still remains a challenge despite a lot of advances in the diagnostics. Therefore, high index of clinical suspicion, appropriate investigations for early diagnosis, and early initiation of treatment actually define the outcome of the disease. And of course, when we are treating fungal infections, especially Candida, it is very, very important to differentiate infection from colonization, which we will see in a few next slides. Yeah. So candidemia is the most common form of invasive candidiasis, the incidence of which may vary from 1 to 12 per 1,000 admissions in our country, compared with 0.05 to 0.36 per 1,000 admissions in Australia. So this was from the study which has been referred to here. Now, nearly 70 to 90% of invasive candidiasis, as per the Indian studies, have been caused by non-albicans Candida species, Candida tropicalis being the most common. And Candida species account for nearly 50% of cases of fungal endocarditis, which is increasing in recent years, partly due to the increased use of prosthetic intravascular devices. Now, if we look at a very important study which has been done across various centers in our country, Dr. Arunalok Chakrabarti being the main lead. So this was a study where multiple centers across India were involved. And as you can see here, Candida tropicalis was the most common species which was isolated. And then Candida albicans, Parapsilosis, Glabrata, Auris, and rugosa. And as you can see in this slide, azole resistance was found in all across, multiple species. And then there is this study later on from the same group where you can see that if we compare the Indian data as compared to the Western data, our rates of azole, especially the fluconazole resistance, seem to be high. And in Candida krusei, as we know that fluconazole has got 100% resistant, and Candida glabrata, there is a dose-dependent sensitivity. Now, if we talk about Candida fluconazole resistance in Candida species across different departments, so the good news is that resistance rates were not found very high in ICU and oncology units, where we see critical syndromes associated with Candida most commonly, unlike the medical wards, OPD, and urology, where fluconazole resistance was found to be in a higher rates. Now, this is these are few characteristics which are associated with various Candida species. So, for example, if we talk about Candida glabrata, it is found mainly in patients who have got malignancies, patients with central venous catheters, TPNs, use of broad spectrum antibiotics, prior exposure to fluconazole, and transplantation, post-transplant patients. Similarly, Candida parapsilosis, we know that it is a little less sensitive to echinocandins with higher MICs. Similarly, the presence of plastics in the body, implanted devices, central venous catheters, that is also a risk factor. And there have been reports of nosocomial outbreaks with this species. And also there is a tendency of this species to form biofilms in various plastics like CVCs and TPNs. Candida tropicalis, as such, we see a lot. However, hematological malignancies and neutropenia, these patients are at high risk. Similarly, Candida krusei, use of broad-spectrum antibiotics and resistance to fluconazole is a characteristic of this species. Again, risk factors like hematological malignancies and neutropenias and prior exposure to fluconazole, recent GI surgery. And then there is this species which we not very commonly see, that is Guillermondi. The names keep on changing. And it is less sensitive to echinocandins and fluconazole. Again, presence of intravascular catheters is a risk factor. So now let's see this case. This is a case of 34 years old male patient with community-acquired pneumonia. He has a central line in C2 and he is on ventilator. So this sputum culture, basically the tracheal aspirate, which was sent from the ICU grew Candida. The blood culture is negative. Now, which of the following is true? Should we start fluconazole for this patient, caspofungin, amphotericin B, or none of the above? So as I was talking, that the presence of Candida in cultures in patients who are in ICU, either from respiratory tracts or from urinary tracts, especially the patients who are catheterized or who have endotracheal tubes or tracheostomy, there the prevalence of colonization of these tracts is extremely common. And Candida lower respiratory tract infection is a very, very rare entity, and actually it requires histopathological evidence to confirm a diagnosis. So whenever we have Candida coming from the respiratory tracts, like in this patient, nothing has to be done. Of course, we have to keep a very close watch, because colonization with Candida, especially when it is multifocal colonization, it can be a underlying, it can be a risk factor, not actually a risk factor, but it can be a telltale sign of presence of candidemia. Now, this is a 42 years old male patient who has got a CSF shunt infection with MR cons. The shunt has been removed. This patient is being treated with vancomycin as per the sensitivity and is improving. Now, the urine routine was sent, which showed budding yeast cells, and the urine culture grew again Candida. Blood cultures are negative. Now, this patient has got a Foley's catheter in situ. However, he is asymptomatic UTI point of view. Now, for this patient, what do we think? What is true? Should we initiate fluconazole as prophylaxis, as he is a high-risk patient and he seems to be colonized with Candida, at least, if not infected? Should we initiate echinocandin as urinary candiduria may be the first manifestation of candidemia? Positive urine culture is likely asymptomatic candiduria in this patient, and changing the urinary catheter always resolves candiduria. So let's see what is the answer to this question. Now, if we talk about prophylaxis to prevent invasive candidiasis in ICU setting, it all depends on what are your prevalence rates and what kind of ICU is the patient is in. And of course, what are the risk factors patient is harboring. So for example, in adult ICUs, fluconazole prophylaxis could be used in high-risk patients with a high rate of invasive candidiasis, which is actually defined as more than 5%. So use of fluconazole or echinocandin both is acceptable. However, it's a very weak recommendation. On the other hand, in neonatal ICUs, where the candidemia or invasive candidiasis is more than 10% and weight of the neonate is less than 1 kg, there fluconazole, not echinocandins, could be used as prophylaxis. Again, prophylaxis strategy varies from ICU to ICU. For example, in GI patients where you have a lot of gastrointestinal surgical patients, there the incidence of Candida or invasive candidiasis will be higher as compared to the cardio and neuro ICUs. And again, the choice of antifungal will depend on the DST of the Candida species, as you see in your ICUs. Now, this is a case of 62 years old male patient who is a known case of COPD for last 10 years, and he has been on oral steroids on and off for last 2 years. Home BiPAP for last 20 months. So he presented elsewhere with fever, cough, expectoration, and breathlessness. However, he was hemodynamically stable. His counts were normal. And he was intubated because he had hypoxemia, and a right IJV was placed, a central line. Piperacillin tazobactam was started empirically, basically to cover up any secondary infection which could be the reason for the acute exacerbation and him needing ventilator. So he started responding initially, but 4 days later, he worsened with new onset fever and leukocytosis. So the question here is whether this is a new onset, a new infection in the hospital which has hit him. Should we think of Candida at this point? What investigation should we start? Should we start empirical antifungals? What treatment has to be changed here? So these are the few questions which are there in our mind, and we will focus mainly on the antifungals. So these are some prediction rules which we have been talking about. However, the role of these prediction rules after the availability of molecular biomarkers is going down. Still, I think they are very good for a bedside jugglery in our mind, which always goes, whenever we have a patient who worsens in the ICU. So for example, if we talk about the best score, so whenever you have a patient with mechanical ventilation in the ICU, with an indwelling central line, with broad spectrum antibiotic going on, plus an additional minor risk factor, including history of surgery, immunosuppressive drugs, pancreatitis, TPN, hemodialysis, or steroids, that increases the risk of Candida. Now, the negative predictive value of this score is higher as compared to the positive predictive value. So if you don't find any of these features, then you can, to a good extent, rule out Candida. However, as I already mentioned, with the availability of new diagnostics, the role of these rules has gone significantly down. Now, the gold standard to diagnose candidemia or invasive candidiasis to a lesser extent still remains the blood cultures. And as we know, that the quantity of blood cultures actually define the sensitivity of this test. So if we talk about bacterial infections, the sensitivity of blood cultures is as high as 95.7% when we set 3 sets. However, in case of candidemia, even with 3 sets, the sensitivity is somewhere around 50 to 70% only, even with the best of the best labs and the Vitek machines. And therefore, also speciation and drug sensitivity testing is equally important, because there may be difference in the sensitivity and susceptibility patterns depending on the species, and you may have higher MICs in your setups. So it's very important at this point in this era to speciate and check the fluconazole and echinocandin sensitivity at least. Because the blood cultures may not always be positive in Candida, we have to rely on some of the non-culture diagnostics, and beta-D-glucan is one test which has been used increasingly in the ICUs these days. So beta-D-glucan is present in the cell wall of Candida. However, this test has to be interpreted very, very carefully, and it has to be always interpreted with clinical and microbiological correlation, because there may be a lot of false positives when you have other fungal infections like Aspergillus, Fusarium, Trichosporon, where also beta-D-glucan is present in the cell walls. Now, treatment with beta-lactam antibiotics in IVIG, hemodialysis, TPN, IV albumin, use of gauze in surgeries, disruption of gut integrity due to chemo-induced mucositis, even septic shock and intestinal ischemia can lead to a false positive beta-D-glucan. Therefore, this test is used more to rule out, because it has got a very high sensitivity but low specificity. Therefore, high negative predictive value is of more importance, and it could actually guide us to discontinue the empirical antifungal therapy in ICU rather than to start antifungals. Now, this is a study from Apollo Chennai, and where again they have mentioned the same thing, that where in patients where beta-D-glucan was less than 80, they could stop the antifungal. So again, they have used this test to de-escalate rather than to initiate antifungals. Now, there are PCR-based assays. Multiple companies have come up, and there are a lot of assays available in the market. Now, as such, PCR is more sensitive than beta-D-glucan to diagnose deep-seated invasive candidiasis. If specificity of both is the same, similar sensitivity of both in candidemia. So yes, PCR is better when you have a non-candidemic invasive candidiasis. Now, if we talk about the best possible diagnostics, so a combination of blood culture with PCR or a blood culture with beta-D-glucan would give you the best sensitivity. However, the problems with PCRs are our experience with PCRs is not very good, and of course, these assays have to be validated properly before we start using them. So if we talk about a rough algorithm, how do we approach a patient with candidemia or invasive candidiasis? So there, some points which we have to keep in mind are, so for example, if you have a patient with sepsis, a non-neutropenic, non-transplanted patient, like most of our patients in the ICU, if there is abdominal sepsis, there the risk of invasive candidiasis is significantly high as compared to candidemia. So along with the blood cultures, try to send a PCR-based test and antifungal therapy source control if needed. However, if your PCRs and beta-D-glucan are negative, then you try to stop the antifungals which have been started empirically. On the other hand, if the source doesn't seem to be abdomen, their candidemia is more likely as compared to invasive candidiasis. And we try to make an empirical choice of antifungals based on the colonization index and based on our prediction rules. We try to rule out other infections, especially the hospital-acquired bacterial GNVs, which we see more commonly as compared to Candida. And then we decide our final treatment again based on the molecular tests and the cultures. So coming back to our patient, so his blood cultures grew Candida albicans, both from the central line as well as the peripheral line. And there was a gap of around 1.5 hours between the two cultures positivity. And as you can see here, it is sensitive to fluconazole. So which of the following is true? This patient should be started on fluconazole, loading dose of 800 followed by 400 mg. Or should we start echinocandin straight away? The treatment duration in candidemia is 14 days. Central line removal is not advised in this patient, and fundus examination is not necessary in all the patients. So if we talk about the choice of therapy in candidemia, the determining factors are basically the criticality of the illness and the susceptibility. So if you have a patient who is relatively stable, so with a mild illness, there you can get away with using azoles, especially, mainly the fluconazole, which is considered as a fungistatic agent. It's not a cidal agent. However, if you have a patient with moderate to severe illness, like our patient who is on ventilator and he has worsened with leukocytosis and new onset fever and who are not stable, their echinocandins, which are cidal agents and which have been proven to have better outcomes as compared to azoles in this subgroup, they are the drugs of choice to begin with. Similarly, if you have a patient where there is history of recent fluconazole exposure, there we should avoid fluconazole due to risk of resistance till we have a confirmed sensitivity in our hands. On the other hand, in a patient who is neutropenic, there most of the times we have patients who have been on fluconazole prophylaxis, and here we also have to take into account hyphal fungal infections. So you have to choose an agent which should cover Candida and Aspergillus both empirically, and preferably a non-nephrotoxic agent. So these are the various points which have to be kept into mind when we choose an empirical agent. So what do the guidelines say? So if you have a patient with suspected candidiasis and when you want to start empirical antifungal therapy, in non-neutropenic patients, you start either echinocandin or fluconazole, depending on the factors which we discussed just now. Liposomal amphotericin B is also an option. On the other hand, neutropenic patients, when you have a suspected fungal infection, liposomal amphotericin B is the first choice because we want to cover Candida as well as hyphal fungi. However, you can start with caspofungin or even azoles, depending again on the stability of the patient and the highest risk of which infection are you actually suspecting. Now, in a patient who has got proven candidemia, there again, fluconazole or echinocandin in non-neutropenic patients, depending on the prior exposure to fluconazole and the severity of the illness, that is the criticality of the patient, and liposomal amphotericin B is the second choice. Similarly, in neutropenic patients, when you have a patient with candidemia, their echinocandins are good, or liposomal amphotericin B. Fluconazole is the second choice in neutropenic patients. Now, when do we check the blood cultures again? So the guidelines say that you should do the blood cultures every day. Practically speaking, every day is not, it's not technically possible to perform cultures every day. So what we usually do is to send them alternate day or at least every third day. Now, central line removal should be done at the earliest in non-neutropenic patient, especially when you are suspecting central line as the source, and it can be removed safely. Of course, the decision is individualized based on the stability of the patient and other factors. Now, after initial treatment with echinocandins in critical patients, de-escalation to azoles can be done in 5 to 7 days, provided the patient is stable, responding to treatment. Your Candida isolate is susceptible to fluconazole, and repeat blood cultures are negative after the antifungal therapy. What should be the duration of treatment? 14 days after the first negative blood culture is what has been taught till now. However, there is a recent paper where they have questioned this duration of 14 days, which is an empirically chosen duration basically. So as I already mentioned, whenever you have invasive candidiasis, start immediate treatment, because delay of every hour in candidemia increases the risk of mortality. Change of central line, fundoscopic examination. This is all very, very important. And if the patient is hemodynamically stable, fluconazole. If the patient is hemodynamically unstable, echinocandins or amphotericin B, and later on de-escalation to fluconazole. So what is called performance measures or checklist in Candida in the ICU? So you have antibiotics which should be stopped if they are going on, if you do not need them. And then you have to repeat blood cultures at least at 72 hours, not later than that. Central line should be removed as early as possible. And echo should be done to rule out Candida infective endocarditis, because we know that Candida metastasizes to the valves very commonly. Fundus examination should be done at least within a week to rule out Candida endophthalmitis, and de-escalation or discontinuation of antibiotics if possible. Now, this is a 64 years old male patient who is a known case of diabetes, and this is an old case and a long history. So this patient started having history suggestive of UTI with dysuria, frequency and burning micturition since May 2016. Now, his urine cultures grew Candida. However, he was kept on getting treated with oral cephalosporins and fluoroquinolones elsewhere. His symptoms and pyuria persisted. Now, there were a lot of urine cultures sent in 2016 and 17, which grew multiple organisms, including E. coli, Enterococcus. And then in June 2017, that is almost a year after he started having symptoms, he was admitted with sepsis and shock elsewhere, where empirical antibiotics were started. They tried to do uroflowmetry, which was suggestive of some obstruction. Even cystoscopy was done. And urine culture had grown Candida at that time, so he was treated with fluconazole at that point. However, the blood cultures information was not available. So his USG abdomen, which was done earlier, showed thickened urinary bladder at many places with marked internal echoes with marked post-void residual volume. Somebody started him on AKT also empirically without any significant response. And then they did a diagnostic cystourethroskopy with hydrodistension of the bladder. Even bladder neck resection was done. And this is the time when he presented to us. He was admitted with high-grade fever with chills, with hypotension and oliguria. So when we did a USG followed by CT, there was presence of gross cystitis with bilateral pyelonephritis. The blood cultures remained negative. Urine culture again grew Candida, and he had a creatinine of 1.6. So empirical meropenem, colistin, and itraconazole was started by the intensivist, and at this point an ID opinion was sought. So looking at this history where he has urine cultures growing Candida again and again, and this is a patient who has received a lot of antibiotics without any significant response. This is the second admission in the ICU. So this is likely Candida cystitis with pyelonephritis with, which is getting complicated by sepsis-like episodes again and again. And this is a very, very difficult syndrome. The reason is Candida in urine in diabetic patients is so common that we tend to ignore it. As I already mentioned that, Candida in urine does not need any treatment. However, in these kind of patients where you have Candida growing from the urine and again, and this kind of profile, you have to keep Candida UTI also in mind. So we asked for the ID and MIC of Candida. The species and DST was important. Itraconazole and colistin were stopped. So I discussed with the nephrologist, and at this point, the nephrologist was not in a mood to start amphotericin B deoxycholate because the creat was already high. So we tried to use high-dose fluconazole. However, there was no response. He still had fever. And then we ultimately started amphotericin B deoxycholate with flucytosine, and meropenem was stopped, and the patient became afebrile within 36 hours. So yes, this looked actually like a complicated, deep-seated candidiasis. And then we got this ID, and it showed Candida glabrata with a good Maltitov score. And as you can see here, Glabrata, as we know, has got dose-dependent sensitivity to fluconazole, which means that if you use very high dose of fluconazole, as high as 800 to 1200 milligrams per day, you can get away with an in vitro resistance and the patient may have a good response. However, in our patient, we had tried with high dose fluconazole and there was zero response. So he was doing well on amphotericin B and flucytosine. However, his creatinine started increasing, his hemoglobin dropped down, and the SGPT became 174. So this is, at this point, he has developed toxicity due to amphotericin as well as possibly due to flucytosine. So both of the drugs were stopped. And now what alternative do we have? So ultimately, this patient was started on micafungin 100 milligrams per day. And as we know that, echinocandins usually are not considered as very good drugs for urinary tract infections because of suboptimal levels. However, there are case series and case reports of micafungin being used in UTI. And, there are in vitro reports as well, where urinary micafungin levels have been found sufficient to treat urinary tract infections caused by Candida. So micafungin is better than Caspo and Anidula as per these reports. Although the urine levels are low, they have been found adequate to eradicate Candida. And similarly, micafungin is one echinocandin which has an edge over the other echinocandins when it comes to the pleural penetration as well. So this was my last case and few more slides. So if we talk about the various agents for the use for the treatment of candidemia or invasive candidiasis, we have polyenes and echinocandins, which are the cidal agents. And then we have azoles and antimetabolites, that is flucytosine, which are the static agents. Now, amongst these, flucytosine should not be used alone because of the risk of fast development of resistance. So it should always be used in combination usually it is used in combination with amphotericin B. Now, if we talk about the spectrum of activity of all these agents against various Candida species, as you can see here, posaconazole voriconazole have got the broadest spectrum. Fluconazole is not active against Cruziae. And again, for Glabrata also, it has got a dose-dependent sensitivity. On the other hand, amphotericin B, again a broad-spectrum agent, sparing one or more species like Lusitania. And if we talk about the placement of these agents in the treatment of candidemia, so let us discuss one by one. Where do we place these agents as the first choice agents? So if we talk about echinocandins, as we discussed, it is the first line of management of candidemia in non-neutropenic as well as neutropenic hosts. First line as empirical therapy for suspected invasive candidiasis in ICU and intravascular candidiasis, including infective endocarditis. Similarly, amphotericin B is the first choice in patients with chronic disseminated or hepatosplenic candidiasis, in neonates, including CNS candidiasis, intravascular candidiasis, including infective endocarditis, and CNS candida. Fluconazole is first-line prophylactic therapy for invasive candidiasis, for orthopedic infections, including septic arthritis, choroidoretinitis without vitriitis, Candida UTI, vulvovaginitis, oropharyngeal and esophageal candidiasis. And now, what are the unmet needs? So Candida auris, yes, it has been a concern in many of the centers. And I know that, not in my center, we don't see Candida auris much, but I know of some of my colleagues who discuss that this is a big concern in their ICUs. So this is one study all across India where they found that overall 90% of auris was fluconazole resistant. and 2% were resistant to echinocandins, 8% were resistant to amphotericin B, and there were multi-drug resistant auris as well to a very good extent in this study. So whenever we have to treat Candida auris, we have to use combination of agents like echinocandins and flucytosine, or amphotericin B with flucytosine, or even echinocandin with amphotericin B, depending on the sensitivity. And similarly, another unmet need in the treatment of Candida and other fungal infections is the TDMs. For example, you may have various scenarios where the TDMs, that is the therapeutic drug monitoring, is extremely important. So, for example, if you have a patient who is a diabetic patient with mucormycosis and develops acute kidney injury, and you have to stop amphotericin B and juggle with the azoles, there you have variable pharmacokinetics of azoles in this kind of spatial population. Similarly, if you have a patient with aspergillosis where you have, immunosuppressants going on, there you have a lot of drug-drug interactions. Again, you may need TDMs. And then you have a patient who is diagnosed with histoplasmosis and the patient is on itraconazole. So they're a disseminated disease, drug toxicities, where we have to use TDMs. And again, patients who are on chemotherapy and who are very immunocompromised patients where you are suspecting poor absorption. So fluconazole TDM is not very, it has not been asked for because of the wonderful pharmacokinetics and pharmacodynamics of fluconazole. However, we have started doing fluconazole therapeutic drug monitoring as well in some of our patients where there is deep-seated candidiasis and, where the response to fluconazole is not very good clinically. And then you have an issue related to the biofilms. So this is a study where they tried to see the activity of various antifungal agents against the biofilms in various Candida species. And what they found is that anidulafungin showed the best anti-biofilm activity in inhibiting the Candida biofilm. So whenever you have central line catheters or other plastics or any other prosthetic device, echinocandins, especially anidulafungin, may prove to be better as compared to the other agents. So summarizingly, early initiation of antifungal therapy in candidemia decreases mortality. Susceptibility, clinical status, neutropenic versus non-neutropenic condition, the PK/PD parameters, drug interactions, toxicity issues may influence the choice of antifungal therapy. Echinocandins have emerged as primary therapy for candidemia and other forms of invasive candidiasis, with the exception of CNS, eye, and UTI. Step-down or transition therapy is recommended in patients who are improving. Infection control measures really need to be emphasized, and judicious use of these antifungal agents will help in the evolving antifungal stewardship. I would stop here, and thank you so much. Questions are invited. Thank you.
Thank you, Dr. Sudhi, for an excellent update on Candida. Wonderful. Please stop the share screen. Okay, so there is one question for Dr. Pratik. Dr. Pratik, are you there? There is one question for you. Can we use minocycline for rickettsia when DOXY is not tolerated?
Yes, Mino can be given when DOXY. Most of the time, DOXY is very well tolerated. Only issue when it is given oral, few patients develop GI side effect. But we can give IV doxycycline. So IV doxycycline don't have many GI side effect. But in case even IV doxy is not tolerated, then IV Mino can be given for rickettsial infection.
Okay, great. So next question is, what is the dose of AZI for typhoid fever? How many days we should give? And why nowadays we prefer it over ceftriaxone, enteric fever?
So the dose for azithromycin in enteric fever is 20 milligram per kg for adult. So it comes to when 50 kg adult is there, it comes to 1 gram per day. So it should be given as a 1 gram orally, OD once a day. And it has to be given for at least 10 to 14 days. as I said that we need to monitor liver enzymes and the QT interval. Nowadays it is preferred because see it azithromycin has excellent intracellular penetration. And then the, I don't remember when the study was done, but there was one study comparing ceftriaxone versus azithromycin. In that thing, the relapse rate was almost zero when azithromycin was given. And one of the theories says that when we give a bacteriostatic drug in a younger patient with enteric fever, it is associated with less toxic sign and symptom as compared to ceftriaxone. So it's not proven, but mainly because of the less rate of relapse associated with the enteric fever, and most of the isolate they are susceptible to azithromycin in our practice. There has been concern regarding rise in azithromycin resistance in the enteric fever, but in our practice we have not seen azithromycin resistance in the enteric fever.
Okay, great. So any more questions, please type. Dr. Surbi, one thing I wanted to ask you, how easily is beta-D-glucan available now? There were some problems earlier, and is the cutoff standardized now? Because these were issues till some time back.
So 80 is the cutoff which is used in our setups. And in our setup, beta-D-glucan is easily available. So in Ahmedabad, 3 to 4 labs do it. The issue is that daily batches are not kept. So it is done just twice a week. So usually the labs do it Wednesday and Saturday here. So the problem is that you do not get the result of beta-D-glucan quickly. So anyways, you have to rely more on your clinical suspicion and your cultures, and you have to, later on correlate it with the beta-D-glucan.
Right.
And also, apart from availability, processing this test properly is more important because it's a molecular test and it has to be processed very, very carefully to avoid false positives, and interpretation is more important as per me rather than, the availability of the test.
So there's a question for you, Dr. Surbi. If fluconazole is resistant to Candida, can we use combination of fluconazole and flucytosine as patient little recovery on fluconazole initially?
So are we talking about Candida and candidemia?
Yeah. He's saying that if fluconazole is resistant in Candida, can we use combination of fluconazole plus flucytosine as patient shows little recovery on fluconazole initially?
No, see, if fluconazole is resistant, then we need a drug which is acting, which has got a proper action, a cidal agent. So flucytosine, when you combine with a resistant drug, fluconazole, not a good idea. So ultimately, there will be suboptimal results because flucytosine alone may not be good enough for candidemia. So the better option is echinocandins or amphotericin B rather than to combine fluconazole with flucytosine. Not a good idea.
Great.
So fluconazole with flucytosine has been, it is there for treatment of cryptococcal meningitis in patients with HIV, but it is not a combination which has been advocated for treatment of candidemia or invasive candidiasis.
Great. So I think any more questions are there? Let me see. So thank you, Dr. Pradeep sir and Dr. Surbi ma'am. The one thing I want to share is that recently a new antifungal echinocandin has been launched and cleared by FDA, risafungin. So it has similar properties to caspofungin, but it's once a weekly infusion. So patients who require prolonged, dosing of echinocandins or antifungals may benefit, risafungin. So that's just a small piece of information I wanted to share. So with that, I thank Dr. Surbi ma'am and lovely presentation, and Dr. Pratik sir. Very nice presentations. Thank you, sir. Thank you, ma'am.
Thank you.
Thank you.
Thank you.
Thank you. Thank you.